Welcome to Teal Talk, an ovarian cancer podcast from the National Ovarian Cancer Coalition. Here experts, survivors, and advocates share knowledge and inspiration for every step of your journey. Subscribe and follow us on social media at NOCC National.
This episode is brought to you by our generous sponsors, GSK, Merck, AstraZeneca, Corcept Therapeutics, Genelux, and Genmab. Welcome in, everyone. I'm Jennifer McClendon, your Teal Talk host. We are so honored to be joined by Dr. Michael Birrer, director of the UAMS Winthrop P. Rockefeller Cancer Institute. Dr. Birrer, thank you so much for being here.
Well, thank you for inviting me. It's really an honor and a pleasure for me to be here.
Thank you so much. So today I wanted to have us discuss some of the incredible progress I think that we've made in both understanding and treating ovarian cancer, from targeted treatments and PARP inhibitors to immunotherapy to it all. And most recently, antibody drug conjugates is a hot topic from what I understand. We want to hear from you. And I also want to discuss how these new breakthroughs that we're seeing through clinical trials have really come to fruition, and discuss their importance and really kind of break that down for those who may not fully understand what their benefit might be. How would you describe where we are right now in the current landscape of ovarian cancer treatment?
Your timing on this issue is impeccable because I trained a long time ago and I've seen the big picture. Just to provide a bit of a historic perspective, when I trained, we were taught using a platinum compound with Cytoxan. The new kid on the block then became Taxol. And then, of course, we eventually got rid of cisplatin because of toxicity and came in with carboplatin. But recognize all of that, and that went on for 20 years. They're chemotherapy drugs, and what's important to recognize is they're completely untargeted. They just bang up the tumor, which is good, but they bang up the bone marrow. So that was the state of the art. And we used to go to meetings and argue about IV versus IP. I think in a lot of ways, relatively unscientific. I think what you're seeing now is completely revolutionized, which is that we've got new agents, they're targeted agents, less toxicity, more effective, more efficacy. That explosion is coming from a much better understanding of the molecular biology of ovarian cancer. And that really took the Genome Atlas study. It took a whole bunch of other work done by many labs, but it's delivered to the clinicians treating this disease just a wonderful opportunity now tailor therapy specifically for patients. It's a very exciting time. I've seen more progress in maybe 5 to 10 years, these last 5 to 10 years, than I saw in that previous 30 years. It's really quite exciting. And there are elements in that evolution that has laid the foundation for personalized precision medicine.
Absolutely. What do you think, from your perspective, some of the biggest breakthroughs in the last decade, or however long you determine, really changed or are changing maybe some of the outcomes for patients?
They really managed to fundamentally change the field. For instance, I did a lot of work in the gynecologic oncology group. I've been a member for now 31 years. We used to randomize patients on trial for randomized phase 3 trials. These are the big trials. And they would have clear cell cancers of the ovary, endometrioid cancers of the ovary, high-grade serous of the ovary, even mucinous tumors of the ovary, because the argument was, oh, ovarian cancer is all the same. We now know that's just crazy, that in fact, all of those tumors are fundamentally different. And so this laid the groundwork, for instance, the creation of the Rare Tumor Committee in Gynecologic Oncology Group. It laid the basis for this approach to precision medicine. We now know, in addition to that, the big breakthroughs are that all high-grade serous cancers are not the same, right? We also know that tumors are not just cancer cells. They have lots of other components, including blood vessels. And so we can target those now with the first targeted agent for ovarian cancer, which is bevacizumab. Those are just revolutionary issues that did evolve from the hard work of a lot of laboratory-based people, but also clinicians. And that's how far we've come in this field.
That's really, really incredible to hear. And with all of this progress, and I know you've talked a little bit already about how it's become more personalized, how has it exactly become more personalized? Can you maybe, for those that are listening or watching, don't understand exactly what targeted treatment therapies are or how you can personalize medicine. Could you speak maybe just a little bit more on that?
Sure. And I'll sort of circa from 35 years ago to now sort of the last 5 years, because this is where the field has evolved and is now state of the art. So we recognize the heterogeneity, if you will, of ovarian cancer based upon some of the issues I've just said. Different histologies, different molecular features, so on and so forth. What it means when patients come to clinic, it's not sufficient now to just sort of say, well, you're going to get a combination of chemotherapy, or you may get surgery, maybe not, and then we're done. What it means is that all of the patients, doesn't matter whether they're low-grade tumors, high-grade tumors, doesn't matter if they're clear cells or whatever, all patients have to have molecular testing. These will look at all of the relevant genes that could be altered in those tumors. But for ovarian cancer, it's very relevant because we now know, based upon homologous recombination deficiency, that about 50% of the tumors will have that defect. Those patients should see a PARP inhibitor because of that. But the reason they have the homologous recombination deficiency is because they have a mutation in BRCA1 or BRCA2, or less commonly, but nevertheless important, one of the other Fanconi DNA repair pathway genes. There's about 15 or 20 of them. That all shows up on that assay. And then the more important issue is that some ladies will have that not just in a tumor, but they'll have it in their germline. And what do I mean by that? I mean that they inherited it, the gene that was mutated. It puts them at very high risk for breast cancer and ovarian cancer. And they will pass that gene on to their children. You can see that you see how things have changed now. They needed testing on their tumor. And then for patients whose tumor is positive, they then need to be assessed and interact with the genetic counselor to see whether that mutation is in a germline, because it's very relevant to the entire family. You go back 15 years ago, maybe we might need to go back 20 years ago. None of that was known. So these ladies who come in with ovarian cancer, they have a germline mutation. We don't know about it, and they're passing it on, and nobody's getting counseled. Nobody's getting screened. We've come a long way just on that alone. And so all of that, and I can tell you in my clinic, we send out the tumor at the same time we send out the blood. We don't do it sequentially because time is of the essence. But everybody with ovarian cancer needs to undergo that kind of testing. And again, it recognized that there is both federal and state laws throughout the country, all states, but also federal law that prohibits discrimination against somebody who gets sequenced, has a germline mutation, and they're worried about losing their insurance. Can't happen.
That's a really great explanation about how we look in personalized treatment, looking at the tumor itself, but then also looking at your family genetics as well. Before we get into some of the current newer therapies, let's talk about how they come into existence with clinical trials. So sometimes we may hear that term clinical trials and just aren't quite sure what they are, or they sound scary, or they sound too involved. I don't even want to go there. But it's so, so important for patients to understand and families to understand what the benefits are and how these really contribute to research. Would you mind just talking about that just some for us?
Yeah, clinical trial is a structured entity that has a hypothesis. Arm A is going to do better than Arm B, or Arm A is going to be the same as Arm B. And so it is a scientific endeavor. And in my view, the only way the field moves forward. If you look at platinum, I mean, I've had this discussion with my colleagues. I had somebody who I had a lot of respect for say, well, I don't really believe in clinical trials. So my response to that person was, so you don't use platinum and you don't use Taxol? They just stared at me. And of course, they realized that the only reason we have those agents is because they were proven by clinical trial. Most of the time, it means they live longer, either progression-free, meaning the tumor's not growing, or they live longer overall survival, which is the gold standard. But there are other endpoints that are also important for patients, for instance, quality of life. So you may have a combination or a drug that doesn't do a lot for progression-free survival or overall survival, meaning living more, but it really provides a higher quality of life. And the FDA has come to recognize that's also important. There are a lot of myths about it. The most familiar ones is patients will come in and say, no, I don't want to be a guinea pig. No, I don't want to be a part of an experiment, so on and so forth. And my mantra on that, I can't tell you how pretty vigorous I will get with that conversation, is that you're not a guinea pig. If the investigators in an institution are doing the right thing, then the trial is the same as standard of care, if not better. If you're
Right.
opening up lousy trials, then yeah, there's an option that you may not do as well. We don't do that. And I've
Yeah.
been at a lot of institutions, I don't know of any place that does that. And if they are, they should be being notified. It's a real opportunity for patients. And I always consider clinical trials, even early on, upfront treatment. If there's a good trial, then that's a real opportunity for the patient. I consider clinical trials part of standard of care.
Now let's discuss some of the current research that's being done in ovarian cancer. And as you mentioned from the top of the program, we're in a really great time. We're seeing a lot of advances, but I kind of want to go back a little bit and maybe start with some of the advances we've heard some about bevacizumab and PARP inhibitors. Could you maybe explain a little bit more in detail about those advances and why they are or have been a major step forward?
Where targeted therapies first found their home in ovarian cancer, it starts really with bevacizumab, which is a monoclonal antibody targeting VEGF. And so it really targets the blood vessels of the tumor. Most ovarian cancers are bathed in a lot of fluid, ascites, and so they don't need blood vessels. So Bev is the first targeted agent that randomized phase 3 trial, GOG 218 and ICON 7, both showed a statistically significant prolongation of PFS. There really was no overall survival advantage, but the progression-free survival advantage, which could be as high as 6 months for GOG 218, was substantial and statistically significant, and the FDA approved the drug for it. Although Europe actually got the approval before us, considerably before us. It took a number of years before FDA actually approved bevacizumab. But I think the advantage and the remarkable nature of that was it was the first targeted therapy in the treatment of ovarian cancer above and beyond carboplatin and Taxol, which is very nonspecific. The second wave, though, brought it an order of magnitude more impressive. To give credit where credit is due, over in the UK, where there was a lot of work looking at DNA repair and how you could target DNA repair. In fact, the first PARP inhibitors were developed to minimize the myocardial destruction in heart attacks. That was the purpose for why PARP inhibitors were developed. Very quickly segued over to say, okay, if you've got a tumor like ovarian cancer, where you have a homologous recombination deficiency, meaning you've got BRCA1 or BRCA2 or one of the other Fanconi pathways are disrupted, you can't undergo homologous recombination. Homologous recombination is incredibly important. Now, how does that relate to PARP inhibitors? Because if you've got a single-stranded break, I mean, remember, DNA is double-stranded. You break one strand, then you need to repair that. And if you don't repair it, it becomes a double-stranded break, and that's lethal for the cell. If you've got a single-stranded break, what repairs it? It's PARP, the protein PARP. So PARP inhibitors will stop the single-stranded repair. If you don't repair that, then the cell dies. And what repairs that? A complex of proteins, including BRCA1, BRCA2, and all the Fanconi pathways. The science was, we got these ladies that got a terrible tumor, and they've got an abnormality in the Fanconi pathway, which is to repair DNA, repairs those double-stranded breaks. So if we make more of them, we'll kill the cells. So that's where PARP inhibitors come in. They convert single-stranded breaks into double-stranded breaks. And then in ovarian cancer, you can't repair them. If it's got a break, use the PARP inhibitor. You might say, well, yeah, but Dr. Birrer, isn't that going to affect all the cells in your body? No, it doesn't, because only the tumor, BRCA 1 and 2, both, on both strands. If you look at the original studies from, I think it was Alan Ashworth over in the UK, if you looked at cell lines that came from a lady who had BRCA loss, and you looked at normal cells, there was 3 orders of magnitude, meaning 1,000-fold difference in sensitivity to PARP inhibitor. That is huge. And so that's really what broke forward. Study 19 was the first trial. Jonathan Letterman led it, and it very clearly showed early on that patients who had BRCA 1 or 2 abnormalities really benefited from it. And then that just exploded into a whole bunch of randomized phase 3 trials, testing not just the original PARP inhibitor, olaparib, but niraparib and rucaparib. These are the three major companies. And the phase 3 trials were positive, showing some real advantages. And the biggest advantage were in the patients who had mutations in BRCA 1 or 2. If you look at Solo 1, it's a home run. Solo 1 took patients who had abnormalities in BRCA genes, and just them, nothing else. They were mutated, and they randomized them to essentially maintenance with olaparib versus no maintenance. And the curves are so far apart, you don't need to be a statistician to prove that they're different. But more importantly, and I find this very exciting, this gets back to sort of something you alluded to, is there's a flattening of those curves. If you look way out on the right, meaning let's go out 60 months, 70 months, 80 months after the trial started, the curve is not dropping anymore, meaning the tumor is not coming back and the patients are not dying.
Okay.
We may actually, it's the first data I have seen where I think we may be curing some ovarian cancer patients. Now, remember, that's a selected group who have BRCA 1 or 2 mutations, but nevertheless, very exciting data and a complete home run.
Oh, that's great. So exciting. Thank you for covering those two. And then I want to move on next to a class of drugs called ADCs, antibody drug conjugates, which is a huge word. I know there's a lot of people out there listening. They're like, what? But it's a huge word. But ADCs seem to be one of the most exciting areas right now, at least in my perspective. What are ADCs, antibody drug conjugates, and how do they differ maybe from traditional chemotherapy, from standard treatment?
So they're another form, in my view, of targeted therapy, but they're target different than the PARP inhibitors. PARP inhibitors target, because they're a small molecule, they target PARP based on that mechanism. ADCs are a combination entity, meaning, what do I mean by that? On one end is the antibody. That's the targeting portion of it. So the antibody, as you know, antibodies protect us from viruses and all sorts of things. And the way they do that is the antibody itself has a very high affinity for its target. So for instance, if you get, let's make it up, you get an influenza infection, you'll develop antibodies which will recognize the viral protein in the influenza virus, and it'll bind to it, and then that'll allow the immune system to mop it up and get rid of it. So that's how you recover from the flu. We've used those antibodies in antibody drug conjugates by taking the antibody, fusing it to what we call linker. And the linkers come in different flavors. Some of them are broken down by proteases. Some of them are reduced. But the linker then links the antibody to the payload. The payload is traditional chemotherapy, so antibody drug conjugate. And when I say traditional, I probably misspoke in the sense that most of the payloads are drugs that we abandoned in the 70s because they were too bloody toxic. So if you give these drugs free in the body, you'll kill the patients. But because it's attached to the antibody, it stays combined. It's not free. And it goes to what the antibody is made to. And what we make the antibodies to are cell surface molecules specific for ovarian cancer. And so it brings in these highly potent chemotherapeutic agents, brings them right to the tumor. Antibody then penetrates into the tumor. That linker is dissolved, and the drug is free to do its bad thing, which is to kill the tumor cell. That's in that tumor cell. And then, as I said before, these are not traditional chemotherapeutic agents. They're 100 times more potent than what we usually give. So you get what's called a bystander effect, meaning when you kill the tumor cell, there's still enough active drug that it's released in its surrounding, and its surroundings are the tumor cells. So the bystander effect is part of ADCs, and it's absolutely very critical to show good shrinkage of tumor. You step back at 40,000 feet, and you can see The advantage here, there's no free drug. So there's no bone marrow bashing. There's no kidney toxicity, no liver toxicity. The drug is targeted directly to the tumor based upon what the antibody sees. Drug is released into that tumor cell. It kills that tumor cell, and there's still enough active drug to kill the tumor cells around it. We've come a long way to determine, okay, what are some reasonably active or overexpressed targets in ovarian cancer. We now know HER2 is expressed, and that TDEX has already been approved for that. The folate receptor alpha is overexpressed in ovarian cancer. That's mirvetuximab. That's been approved. So we got 2 drugs that are approved based on this technology. But there's a whole bunch coming. There's TROP2, there's NaPi2b, there's MUC16. These are all in clinical trial right now. I have this discussion all the time with one of my colleagues. So you've got a platinum-resistant ovarian cancer, right? Because that's sort of the end stage, and that's tough to treat. We know the median survival is about 11 months for those ladies. But the tumor expresses, I'm making it up, folate receptor alpha. They're eligible for mirvetuximab. And we give her mirvetuximab, the tumor shrinks, and they get 8 to 10 months prolongation, progression-free survival. The tumor also expresses Claudin-6, and we've got an antibody for that, an antibody drug conjugate for that. So it expresses 2 surface molecules. So after the folate receptor, now you give the Claudin-6. And then maybe it expresses MUC16. So after that, you give the MUC16 antibody drug conjugate. Now, you would argue to me, well, Dr. Birrer, how can you do all that? Because we know when we give chemo, you run out of bone marrow after a while. Well, because this is not bashing up the bone marrow. We could be giving our ladies 8 to 10 months per antibody. Next thing you know, you're out 30, 40, 50 months. When I say that to my patients, they say, oh, sign me up for that. I love it. The antibody drug conjugates, there are some subtleties in it, and there may be some cross resistance, but I think it's a whole class of drugs which are going to find their home. Some of them have already found their home, but they're going to find their home in the treatment of ovarian cancer, mostly initially in platinum resistant. Some of them are going to move forward, maybe even up front, and replace taxanes. Because if you ask ladies, when they get carboplatin Taxol, what's the worst drug? By far, it's the Taxol. Neuropathy, you lose your hair, it's terrible.
Yes. I was just going to ask you, just out of curiosity. So, yes, if you think about chemotherapy, those taxanes being what you call a free drug, meaning that it goes everywhere in the body, attacks everything in the body, with in the future, maybe one day, if these ADCs were to be upfront and in place of those wouldn't exist, those side effects, or be lessened?
Yeah. Mirv, for instance, is already being tested up front as a substitute for the taxane. A randomized phase 3 trial. My guess is it'll pass. It's a very active drug. So you're going to get rid of all the hair loss, the alopecia. You'll get rid of all the neuropathy. So yeah, I think it's going to revolutionize how we approach ovarian cancer. And the other thing I didn't have time to go into, but even in the technology, Mirv is an old drug. There are now better versions of that, where what we call the DAR, D-A-R, the DAR, that's drug antibody ratio. There's technologies now where you can attach more drug to the antibody than we used to. And more importantly, you can actually define how many molecules you put on. In the past, it was sort of a random event, and we didn't quite know how many payloads we were providing the patient. But now it's all changed. It's all defined. We can also theoretically put on 2 different payloads. We can put a microtubule payload, and we could put a topoisomerase 1 payload. So you're getting 2 drugs targeted to your tumor.
Wow. I had known about tumors having these receptors, or these, sometimes we call them the biomarkers. I wanted to ask you about that in a minute. We use the term biomarker to identify a clue of, here's me, target me with this certain drug. But I didn't know that you could have more than one on a tumor cell and do more than one type of targeted treatment on that one tumor.
So for instance, folate receptor alpha, and then you look at NaPi2b is another surface molecule. There's about a 30% overlap between those 2 molecules. So there's going to be some tumors that have both.
Would it be appropriate, because we do a lot of biomarker education, trying to educate patients and families on these clues. Is that what you're referring to when you say surface molecules?
Correct. These are 2 of our biomarkers. And when you talk about ADCs, they really need to be expressed on the cell surface. Otherwise, the antibody is not going to see them. And the question that we discussed a little bit early on is there's even another ultra sophisticated ADC, which got accelerated approval, right? JNK003, I believe.
It was in the news last week. Yeah.
At JSK, yeah, and 003. That's actually really interesting because there the antibody recognizes two different sites, non-overlapping, on the same molecule. In this case, it's HER2. So the reason why that's important is it means it binds even more securely to the target. And again, they applied and got accelerated approval, or fast track, if you want to call it that, because the response rates were close to 75%, and that may reflect the increased affinity. In phase 2s for ovarian cancer, when you have these advisory boards, we usually recommend you're looking for something with 30% activity, 30% response rate. Those days are gone. I think with bevacizumab and its agents like this, the bar has now gone up to about 50% response rate. Otherwise, it's not worth developing. Duration of response is important too. If it's a quick, okay, response, but it only lasts a couple of days, that's not of great value. There, we're usually looking for 6 months duration of response.
You mentioned talking about some of the side effects of our traditional standard drugs. What about side effects from ADCs? Because sure you've heard, there's a lot of patients that we encounter that are having a tough go with some of these ADCs and have to eventually quit that therapy because of side effects. Could you maybe speak to some of those and what we might know about how to help those?
Well, the profile is fundamentally different than chemo. So while there can be some myelosuppression, meaning suppression of the bone marrow, it's not anywhere as dramatic as carboplatin and paclitaxel. So that's the good news. The bad news is, there are some toxicities. So for instance, MERV, which I did a lot of work with when I was up at Harvard, it was my patient that first described the ocular toxicity. I still remember that morning when I went to my lab meeting and everyone said, she's doing fine, no problem. I got back to my office and she left a message saying, Dr. Birrer, I'm blind. And I said, oh my goodness. But the truth is it's a keratitis. She wasn't blind. She had blurred vision, which was uncomfortable. But in that case, it's 100% reversible. And actually it's mitigated by using steroid eye drops or lubricating eye drops because it's a keratitis. But I think a lot of that has to do with payload. That payload is a microtubule inhibitor. We don't really see it as much in the topoisomerase inhibitors, which are now in place and frankly are more potent. The topo is very potent, and so we do see a little myelosuppression with that. You have to be careful. But the other dreaded one is that there's some ADCs that cause an interstitial lung disease. Mechanism not completely clear. MERV, for instance, binds to the folate receptor alpha. There is folate receptor alpha expression in type 2 alveolar cells. But there's other mechanisms involved, whether it's just free antibody, it's not clear, but that needs to be followed carefully because they need to come off therapy. They need to take a holiday, and some of them will need steroids.
Okay, so that's something that they monitor for. Wonderful. That's a really exciting area for sure. And we're coming close to the end because there's a lot to talk about. Would you touch a little bit also on immunotherapy? Maybe explain exactly what that is, what's happening in that space?
Perfect timing for that question because the confusion about immunotherapy is a lot of people think that's ADCs, antibody drug conjugates. The antibody is there, but the antibody drug conjugate is really standard chemo. It's just targeted. It's got nothing to do with immuno-oncology drugs. And immuno-oncology drugs are designed to basically reactivate the immune system to eat the tumor. And, this whole field broke open now probably 15, 20 years ago with immuno-oncology treatments of melanoma, skin cancer, where there were these just dramatic responses where you treat with one of the immuno-oncology drugs and the tumor just melts away. And it's melting away because the patient's own immune system is fighting it. Now you would say, well, why wasn't it doing it to begin with? Because these tumors are smart. These tumors put the T cells to sleep. That's what they do. PD-1 is a molecule that basically tells the T cell, which is your immune cell, stay away, go to sleep, don't do anything. So the anti-PD-1s, which are the most common drugs that we use, bind to that and it blocks the signal. And the T cell becomes that. So that's the good news. It's been dramatically effective in a lot of tumors, mismatch repair tumors, both in the endometrium in colorectal tumors come to mind. This shows you how the fields have changed. When I was a fellow treating metastatic colorectal cancer to the liver, you know what we did? Nothing. We would put them on hospice because the only drug we had was 5-FU, which had an 18% response rate. And most people didn't think it was worth it. We can now cure some of those patients if they have mismatch repair abnormalities by giving them an immuno-oncology drug, and the tumor just melts. So it's very exciting. That's the good news. The bad news is it's very checkered history in ovarian cancer. I was at a meeting the other day where someone quoted that there have been almost 10,000 patients put on immuno-oncology drugs for ovarian cancer. I think that's a bit of an exaggeration, but there have been multiple large randomized phase 3 trials, all of which are negative. No better than standard of care. One arm is maybe chemo plus an IO agent, immuno-oncology drug. The other arm is just chemo, no difference. So that part has been depressing. The scientist in me tells me I'm not terribly surprised. I think one of the misleading interpretations was because ovarian cancer has homologous recombination deficiencies, because it has, and that's why they're sensitive to PARP inhibitors, that they must have a lot of what we call neoantigens, meaning that they have a lot of mutations floating around that create new proteins that the immune system can recognize. That was probably misleading because the homologous recombination deficiency that you see in ovarian cancer causes large chunks of DNA to move around. It doesn't cause small mutations like you see in lung cancer from smoking. So I think that explains part of the reason that simple use of IO agents in ovarian cancer has failed. That doesn't mean immuno-oncology is off the table. I think novel combinations with either anti-angiogenic agents or 2 immuno-oncology drugs, and this is where the field is going, might be active. It might be effective. The other thing, to be fair, I was at ESMO and the European group presented a study, which is basically Aurelia, which was a European study where they used weekly Taxol plus Bev and showed a really dramatic response. They combined that with pembrolizumab, which is an immuno-oncology drug, compared to just weekly Taxol and Bev. And they reported a statistically significant prolongation of PFS of about 5 months in platinum-resistant ovarian cancer. It was the first trial to show a signal like that. So I don't know what that means. Maybe if it's random chance, or maybe there's something there with that particular combination. So it's not over yet. And I think novel combinations are coming down the pike also.
So before we wrap up, we talked a little bit about clinical trials. For those that are here with us today, how can they start that conversation about clinical trials, or how do you best go about finding them? Because I know it can be quite complicated.
Well, as I said before, I think it's really important to describe what a clinical trial is, be optimistic about it. That's got to be standard of care or better. Otherwise, it's a lousy trial. That shouldn't even be on the table. But I will say this, and I experienced this when I was at Harvard. It was in some ways challenging. I used to get ladies coming in at MGH with about 300 pages of Google searches. That's actually incredibly helpful.
It is.
So it's not something to be feared. But if patients come in and they want to do some work on their own, then I usually steer them to 1 or 2 sources. And there could be others, but certainly clinicaltrials.gov is the master resource. It is a requirement that every trial in the United States has to be listed there. The only problem with it is it's kind of a bear to get around. And so I usually say, okay, why don't you go on and play around, but feel free to come back and ask questions or print out things and I'll take a look at it. The other one is American Cancer Society as a more friendly website, I think. But that's also another good source of information.
Sure. Absolutely. Thank you, Dr. Birrer. It has been such an honor. So much great information. You've explained some wonderful, wonderful concepts to us. Thank you so much for joining us today.
My pleasure. Thank you so much for doing this. You do a sacred thing here.
If you'd like to learn more about clinical trials or some of the emerging therapies that we discussed today, you can visit our website, ovarian.org, for those resources, patient guides, and learn about our support programs.
Thanks for listening to this episode of Teal Talk, an Ovarian Cancer Podcast. This program is made possible thanks to supporters like you, who help the National Ovarian Cancer Coalition bring connection, education, and hope to survivors and families nationwide. Learn more or donate at ovarian.org. Until next time, stay informed, stay empowered, and take care.